Dr. Doug Lucas here, retired orthopedic surgeon, now focusing my practice on bone health and health span. If you have osteoporosis or osteopenia, you have probably been told to take calcium. One of the challenges that I see with my patients coming into our program with concerns about bone health is that they listen to their doctor who says, take 1,000 to 2,000 milligrams of calcium in supplement form. And then they listen to influencers and celebrities that say, calcium is not the problem, don't take any calcium. And boy, there's a whole sea or world of information in between. And it's really tough to know who you should listen to, what you should do. So I'm going to dig into a little bit of why our recommendations in the US are 1,200 milligrams of calcium for women over 50, and why in other countries it's 700 milligrams and the World Health Organization says 500 milligrams. There's so much confusion here. So I want to dig into the research a little bit to help determine why these numbers are here in the first place, what they really mean, and how you can help guide yourself down this very confusing pathway of whether or not you should supplement, where your calcium should be coming from, etc. So stick around. So like I said, in the United States, the recommendation is to take 1,200 milligrams of calcium for women over the age of 50, and this comes from the National Institutes of Health. When you dig into where these recommendations came from, there's various opinions and there are statements from the NIH and other organizations, but really it comes down to some kind of landmark studies and then some extrapolation of that data. So whenever we're talking about the recommended daily intake, which are recommendations from the government to the public, generally to avoid acute illness. Now, usually you'll see me talking about the RDI, or recommended daily intake, in a way such that we need to probably take more than what's recommended for optimal health. Well, this is the rare circumstance or circumstances where we actually probably want to aim lower, and I'm going to explain why. If you look at the studies that demonstrated what a balanced intake is, and these are the types of studies that they use to demonstrate RDI, a balanced intake meaning that your intake is equivalent to your output. In other words, you're not consuming too little, too much. You can see studies that go all the way back to this 1952 study showing that 100 to 200 milligrams of calcium is all that you need in a controlled environment. More modern studies with modern techniques would show that that balance is somewhere around 740 milligrams of calcium. So which one's right? And where did we get 1,200 from? All right, so what's important to remember when you're looking at studies like this is that these are science-heavy laboratory studies. So they're looking at patients in a controlled population and doing their best to try to figure out the intake and the output and to try to determine what's happening on the inside. The problem with calcium is that calcium is very strictly regulated. So calcium levels really don't change much in the blood unless you change some pretty significant other variables. So when it comes to watching how much somebody eats and then looking at either their urinary output, their metabolism of bone, there are a number of variables that you can look at, but it's kind of hard to control all the variables on the inside. And that's why you can see these wide ranging studies showing that, potentially down at as little as 100 milligrams up to, 700, 800 milligrams. When you start looking at more population studies, you get even more confused because there are studies that show that some populations would have consumption down in the 200, 300 milligrams and have no increased risk of osteoporosis or fracture. And then countries that consume a lot of dairy end up having higher consumption of calcium, but also higher risk of fracture. So it's really hard to know what to make of all of this. So I think it's really important that we dig into the literature that actually looks at calcium as an intervention, randomized control trials. Do they actually have an impact on fracture risk? What is the impact on bone mineral density for what that's worth? And what else can we glean out of those studies? So here we go. All right, so this next study is a 2007 study out of the American Journal of Clinical Nutrition. So this is a meta-analysis, and really this is looking at fracture risk. So this is ultimately what we want to know, right? So we want to know, is consumption of calcium or supplementation of calcium going to change our fracture risk over time? Now, this particular study looked at both randomized control trials, but they also looked at cohort studies. So you could argue that we only want to know about randomized control trials, but actually the cohorts give us quite a bit of information too, because if you can track people over a long enough period of time and track the variables that you are interested in, you can actually get much bigger studies this way. So this one, when all combined, had over 170,000 women with over 3,000 hip fractures. So this is pretty good data. So digging into this, we can really take out some pearls, which are going to help us to make some recommendations. Okay, so the first part of this is on the results of the observation. So the cohorts that they followed over time, you cannot look at any variable there and say that this was a cause of anything with this type of study. But what you can do is show an association, a linkage, some kind of you did this and this happened. We think that they're causal, but we don't know that. So what we're looking for here is, did the consumption of calcium change fracture risk in these American-based populations? And the answer was no. Calcium intake did not change the risk of fracture over time. So very clearly in the cohorts, we can say that likely there was no association there. One of the challenges, of course, is that in an association-like study or these cohorts, we're asking patients to recall what they eat or do 24-hour recalls or even food frequency questionnaires, which are even less accurate. So I always want to know what the RCT data shows if it's available too. And in this case, it is, although RCT data is generally going to be on supplementation, not necessarily on intake, whereas the cohort studies are more on intake. But from a supplementation perspective, this study looked at 6 different RCTs and 4 of them had hip fracture data. So we can get a sense of what did the calcium supplementation actually do for hip fractures. So interestingly, when you look at this data, it's surprising to see that these data show that there is really no difference in calcium supplementation versus calcium consumption, meaning that if you ate it or if you consumed it as a tablet, neither one of them seemed to have a positive benefit or effect on the risk of hip fracture. What's also interesting, though, is that in these studies, there was a significant increased risk of hip fracture in those that were taking calcium supplementation. So you could almost argue, oh my gosh, nobody should be taking calcium supplementation, not only because of the risks of stroke and heart disease and kidney stones, but oh my gosh, it's actually going to make me increase my risk of fracture. Well, not quite. I think we need to look a little bit deeper into the data to see what the potential weaknesses of these kinds of studies are. So what kind of weaknesses am I talking about? Well, the problem with randomized controlled trials on supplements is that in general, the numbers are very small. So you're going to have studies on, tens of people, not hundreds, thousands, or hundreds of thousands of people. So there's going to be some weaknesses there. Adherence in supplement trials is generally poor. People just stop taking the stuff, with the exception of the trial I'm going to talk about in a minute. And also there's some bias, because if you're looking at groups of people and you're just looking at what was recommended to them and not necessarily why, you might find that, oh my gosh, actually the people that were getting calcium supplementation had worse osteoporosis and therefore had a higher risk of fracture in the first place. And that wasn't necessarily controlled for in these studies. So we can't just walk away from this and say, no calcium supplementation, it increases your risk of fracture. I don't think that's quite fair, but you could argue that, boy, we should really prove if there is benefit based on anything else. So what can we look at? All right, sorry to interrupt, but if you are enjoying this content, please do me a big favor and click on the subscribe button. The more people that subscribe to this channel, the more people that the algorithm of YouTube and other social media platforms will deliver this information to their stream and feeds. So if you could do me that big favor and subscribe, that would be really helpful for our mission of educating more people about how to manage osteoporosis and bone health concerns on their own. Secondly, if you want to learn more about how we manage osteoporosis, look for the link for the free masterclass in the description below. This is where you can get a sense of other things that you can do for yourself, hopefully ask some questions to the team, and potentially really make some big changes in how you're actually managing your bone health. If you want to learn more about how we do things in our program and you want to speak to our team, look for the link up here. You can click on that and follow that form, and it'll get you to the right people. All right, so if calcium supplementation doesn't really reduce fracture risk, according to those studies, what does it do for BMD? Does it actually increase our bone mineral density, which then potentially secondarily could help improve our fracture risk? Well, there are some controversial comments and studies out there, and the study I pulled to review, I think, will help us to sort of figure our way in between these different opinions. So this is a 1994 study. It's well designed because it has 3 groups. It has a control group, which is always good in an RCT. And then it has 2 calcium groups. It has a 1,000 milligram and a 2,000 milligram group. And this is calcium alone. So we have to take it for what it is. But I like that there are 2 groups of intervention and they are at different dosages. So this study also interestingly ran for 3 years. So this is a long study. Not all of it ran that long, but part of it ran out to 3 years, and you could really see some interesting changes there. And it had about almost 300 women in it, but their age group was interesting. Their age was 46 to 55. The reason why this is interesting is that most studies on calcium supplementation and osteoporosis are in postmenopausal women. It almost makes sense because that's the population that you're generally targeting. But my opinion and preference is if we can treat this problem earlier, we're going to have to make less changes to have a bigger impact. So I like this study looking at women aged 46 to 55 because that is actually the age group where you're going to have the biggest impact with subtle changes. So the 3 groups of supplementation I already mentioned, and then they also subdivided those 300 women into where they were in their menopausal progress. So they had a premenopause group, a perimenopause group, and a postmenopause group based off of specific symptoms and guidelines. And then they measured over the course of this time bone mineral density. They did not talk about fracture risk, but this study is not big enough to really identify significant fracture risk statistically anyway, so it wouldn't have been helpful. So we're really just looking at bone mineral density. So the results showed that if you supplement with either 1,000 milligrams or 2,000 milligrams, over the course of the first year in the whole group, in all women, there was an increase in bone mineral density. But if you compare both of those 1,000 and 2,000 milligram groups to the control group over the course of the next year, the second year, and then the next year, the third year, then the 2 lines balanced out so that there was no difference between those 2 groups. So a lot of people who are against calcium supplementation will use this study specifically to say, see, calcium supplementation doesn't do anything. But you have to dig, as usual, deeper into the study and the results to see if there are any variations that you can take a little bit of information out of. So I agree that it would look like that even at 2,000 milligrams, calcium by itself did not have an increase in bone mineral density for these women. However, when you subdivide them, and this is why they did this, when you subdivide them in postmenopausal, peri, and pre-menopausal, what you can see is that for the women that are still cycling, or at least irregularly cycling, those women do see an improvement in bone mineral density with calcium supplementation over control, even at the 3-year mark. So while postmenopausal women are not building bone rapidly enough to probably utilize the calcium, whatever they can absorb if it's given alone, premenopausal women do. And so I think what you can take away from that is to say, well, there are really 2 different questions being asked here. The question that most people are asking is, does calcium supplementation slow down osteoporosis? And if you think about that question, it doesn't really make sense that it would. Why would it? Because it's bone metabolism. So if we're trying to slow down osteoclast function and breaking down bone, calcium by itself wouldn't do that. Calcium and vitamin D may do that, but it probably has nothing to do with the calcium. If slowing down osteoporosis is your goal, calcium's probably not going to be your primary tool. However, if you want to build bone, you need the building blocks. So when we bring patients into the program, we say, okay, why are you losing bone? Let's stop your bone loss. Let's rebuild bone. If you're going to rebuild bone, you need the building blocks to build it. So that's not just calcium, though. Calcium is probably part of that, but it's not the only thing. There is a long list of things that you need to build bone. Protein, other minerals, all the things that go into building bone. It would be like an analogy of saying, if you wanted to slow down muscle loss, should you increase protein intake? Well, it might have an impact, but it depends on why you're losing muscle, right? But then think about, well, if I want to build muscle, am I going to increase my protein intake to give myself the building blocks? Of course you are. That just makes sense. I see the same thing for people that say, well, I want to go on testosterone or peptides, to build muscle mass. and then they take the thing and then they don't get any better. And it's because you still have to have the building blocks. You have to give your muscles the stimulus. So the same thing is true with bone. We've got to give the bone the stimulus to build and then give it the building blocks to build bone. And then you can actually make some bone. So I think with the research, we're kind of asking the wrong question. Really, we should be saying, can calcium be utilized in a comprehensive approach to help build bone? And that study I've never seen. So I don't know that we fully know the answer here, but I think if your goal is to build bone, which it probably should be, give your body what it needs. The challenge then is how much? So is 1200 milligrams too much? Well, it's a lot. If you're getting that much through diet, I think that's great. If you look at other countries like the United Kingdom, for example, in Britain, they recommend, I think it's 700 milligrams and recommend you get it mostly through diet. Other European countries kind of fall in line with that. World Health Organization, like I said at the beginning, 500 milligrams all through diet. They don't even talk about calcium supplementation. I think that we need to make sure what we're getting using, we use Chronometer or some kind of a tracker so you know what you're getting through diet. And then supplement to some level. And this is where there's a lot of nuance. So for people that are really pushing hard, maybe you do push up to 1200 milligrams. But for my patients that are having to take big doses of supplementation to get there, I tell them that I don't know that that's the right thing to do. And then we probably bring that level down some. So this is something where you really have to come up with a plan that's right for you, working with your providers, your healthcare team. We're always adjusting this for our patients. But what we have come up with over the last, a couple of years is that we really don't just aim for that 1200 milligram mark and hit it. We are actually becoming pretty flexible there. We're bringing that number down the more we dig into this research, and we're seeing results of people that are consuming way less calcium than that on a daily basis. But you have to consume enough. So I hope you found that helpful. This is a challenging topic, but I think that if you can put together how much you're consuming through diet and then try to figure out, how quickly are you trying to grow bone? How aggressively are you trying to be? And then working with your team to come up with a number there, then that's something that should be pretty attainable without big doses of supplementation. So thanks for getting to the end of this video. If you enjoyed this, please subscribe. It's really important. The more people that subscribe, YouTube will recommend this to people that are looking for bone health content. So you'll help them to find the content that they need. If you want to learn more about how we manage osteoporosis and other tips and tricks you can do on your own, look for the link for the free masterclass in the description below. If you want to talk to our team about our programs, we have both full service programs and group coaching programs. If you want to learn about those, look for the link up here. That'll take you to a form to get you in touch with our team. And then lastly, I want to hear from you. I love the comments, the questions, the community that we're building in YouTube. So please leave those below. We answer those on a daily basis and we'll get to yours as quickly as we can. Thanks again for making it to the end of this video.